I'll be talking about retained intraocular foreign body, a test of your skills. And this is a voiceover, this is a potpourri of cases where we have collected from basic level to a very complicated situations.
We have no financial disclosures to the content of this presentation. Intraocular foreign bodies are seen in up to 40% of all open globe injuries. The presence of an intraocular foreign body in the vitreous cavity or retina is an ocular emergency and calls for an urgent removal in order to avoid the risk of endophthalmitis and its sequelae. Repeat intraocular foreign body removal can be surgically challenging for any VR surgeon. Intraocular foreign bodies can be of various materials such as metal, wood, glass, plastic and others, and their removal therefore could pose different challenges in each of these settings. This video depicts a series of surgical scenarios wherein surgeons have tried to remove intraocular foreign bodies of different size, shape and nature using different kind of instrumentation. Case 1. A metallic intraocular foreign body with endophthalmitis. A 37-year-old male patient presented with sudden diminution of vision in the right eye following injury with a flying metallic object. His best corrected visual acuity at presentation was PL plus PR accurate. He had a self-sealed corneal wound and a cataractous lens with signs of endophthalmitis. The wound, which was partially leaky, was repaired and a 23 gauge pars plana vitrectomy was done. Initially, all the loose vitreous exudates were removed, following which a PVD induction was carried out with the help of a cutter. A 360-degree vitrectomy was completed and the metallic foreign body was freed from its vitreous attachments. An intraocular magnet was used to pick the foreign body from the surface of the retina. A careful attempt was made to align the foreign body with the long axis of the magnet to allow for easy removal through the port. But not all foreign body removals are as straightforward as this. This second case highlights the struggles of a surgeon while removing a larger metallic intraocular foreign body using a magnet and a forceps. After completing the vitrectomy to remove the vitreous hemorrhage, the foreign body was picked from the surface of the retina again using an intraocular magnet. But as we were trying to take out the foreign body through the port, due to its large size, it got stuck at the vitreous base. This is a judgment error where a smaller port was made compared to the size of the foreign body. We tried multiple times but struggled and eventually had to enlarge the port using a MVR blade, and then the foreign body was slowly slid out off through the larger port. Both these cases were iron foreign bodies which are magnetic and were relatively easy to take out, but not all metals are so forgiving. The third case is a rare case of a retained copper intraocular foreign body which presented with severe retinal chalcosis and cataract. The patient's best corrected visual acuity at presentation was 6/60 with a cataractous lens and a retrolental copper wire. The fundus showed dense vitreous haze with a perfuse optic disc and a reddish golden hue to the retina and the vitreous, suggestive of chalcosis. The cataractous lens was removed by phacoemulsification, following which a complete vitrectomy was done, especially around the foreign body, which was first grabbed with a forceps and gently freed of all its vitreous attachments. Using a handshake technique with two forceps, the foreign body was aligned with its long axis in the axis of the forceps and was then gently removed through the 23 gauge pars plana port. Subsequently, the intraocular lens was put in its place and the vitrectomy was completed. In spite of the signs of severe chalcosis on the retina, the patient did recover to a best corrected visual acuity of 6/12 postoperatively. All the above cases were managed relatively comfortably because of a clear cornea and a good visualization. But what to do if the cornea is opaque because of trauma or damaged severely? Our fourth case here is a 38-year-old one-eyed male who had a severely damaged cornea following a blast injury. His ultrasound showed presence of multiple retained foreign bodies in the vitreous cavity and a ruptured lens with lens matter filling the anterior chamber. We were suspecting stone foreign bodies in this case, which were similar to stone foreign bodies seen embedded on the surface of the cornea. The damaged cornea was refined and removed, and a temporary keratoprosthesis was sutured in place to allow us to visualize the vitreous cavity. We could see ruptured lens matter floating out as the cornea was being refined. After securing the keratoprosthesis in place, first the anterior chamber was cleared of all the residual lens matter and the remnants of the lens capsule were removed. A 23 gauge pars plana vitrectomy was done and stone foreign bodies were seen lying on the surface of the retina. A three-pronged claw forceps was used to pick these foreign bodies one by one and remove through the ports. The ports were closed, the temporary keratoprosthesis was removed, and the corneal graft was sutured in its place. Our last case here can be a significant challenge for even the most experienced VR surgeons. A 36-year-old male patient presented to us with loss of vision in the left eye following an explosion injury 1 month back. He had undergone a scleral tear repair 1 week back elsewhere. His presenting visual acuity was PL plus PR accurate. The anterior segment showed a repaired scleral tear with pupillary peaking and cataract. There was no view of the fundus. Ultrasound B scan showed presence of a retinal detachment along with a large retained intraocular foreign body. After a 360-degree conjunctival peritomy, a 240 inserting silicone band was secured. The cataractous lens was removed using phacoemulsification. A large wooden foreign body was seen floating in the mid-vitreous cavity. But first we decided to tackle the retinal detachment. It had already started showing signs of early PVR. A 360-degree careful vitrectomy with base dissection was done, and the pre-retinal bands were carefully removed. PFCL was put at the posterior pole and the SRF was drained through the peripheral breaks. Once the posterior pole was flattened, we decided to remove the foreign body. Since it was a large foreign body, we decided to take out from the anterior root, enlarging the cataract incision. Multiple attempts were made to take out the foreign body with the help of two forceps using the handshake technique. But unfortunately, we could not find a forceps either having a good enough grip to hold the foreign body or having a large enough mouth to hold it securely and to remove it through the limbal incision. Eventually, we floated the foreign body up using the help of PFCL, and then after enlarging the limbal incision, a wire rectus with indentation was used to slide the foreign body out through the corneal incision. It was almost similar to delivering a hard brown nucleus during an extracapsular cataract extraction. Subsequently, the vitrectomy was completed, the retina was flattened using PFCL, and a 360-degree laser was done. Lastly, a PFCL silicone oil exchange was done. The patient recovered a post-operative best corrective visual acuity of finger counting 1 meter. To conclude, retained intraocular foreign body pose quite a significant surgical challenge by themselves for any VR surgeon. The task becomes even more daunting when these are further complicated by the presence of either vitreous hemorrhage, retinal detachment, endophthalmitis, or a compromised view. The successful management of such cases thus requires an array of different surgical techniques, varied instrumentation, a well-formulated pre-operative plan, and a prompt per-operative adaptability to alter that plan as and when required. Thank you.
Thank you very much.
Very good compilation of cases, Dr. Gupta.
Any questions from the audience? Uh, so that's what the problem came in the last patient. We didn't had. I tried using MacPherson also. Uh, Actually, there is a very wide-pronged foreign body forceps which is available with what we call as an Bape forceps. But I didn't had in my armamentarium that time, so I had to float this up and bring it into the pupillary area. And there, a few people have used basket kind of a thing for what they use in removing stones from the urethra. So that has also been used, but I didn't expect it. And I thought I'll bring it into the pupillary area and take it out from the limbal wound. But
The only intraocular foreign body that we left and we could not take it out till date is one very big glass foreign body. We didn't know how to hold it.
glass foreign body, actually you can hold it because one surface is flat.
Very
So
thick.
uh, if it is very thick, then it becomes a problem. Then you will need a very large forceps for that.
This topic is striking the ocular chemical injury.
I have no financial interest. So ocular chemical injuries constitute 20 to 30% of all ocular injuries, and chemical injuries are called when a corrosive substance is accidentally introduced to the eye or periocular tissue. It's a true ophthalmic emergency that requires immediate and intensive intervention to minimize severe complication and profound visual loss. It is most prevalent among young males between age 20 to 40 years, but children are also at risk. So there are common offending agents like in home. We usually use it for household work like cleaning solutions, drain cleaners, oven cleaners, bleach or battery explosion, and some are industrial explosion like various alkalis and acids which are used in industry. So after chemical injury, first the acute clinical findings are periorbital edema and erythema, depithelialized skin, loss of eyelashes and eyebrows, corneal and conjunctival epithelial defects, chemosis, conjunctival inflammation, limbal ischemia, corneal cloudiness, edema, and occasionally perforation. Other clinical findings may include cataract, high intraocular pressure, and secondary damage to retina and optic nerve. So one of the most important prognostic factor for visual outcome is the extent of ocular surface damage, initially reflected by the amount of limbal ischemia. The common element in all these classification scheme is the amount of limbal involvement at the time of injury, and relative proportion of surviving limbal tissue is a major prognostic factor. So accordingly, there are two classifications. First, older one are Roper Hall classification, which are based on involvement of corneal epithelium and limbal ischemia, and the recent one is Dual's classification, which is graded in 6 types, and it involves limbal involvement and conjunctival involvement in percentage. The course of disease varies in 4 stages. First is immediate, acute, early repair, and late repair stages. So in immediate stage, we have to do thorough irrigation of the ocular surface with at least 2 liters of water until the pH of the surface become neutral. So if nothing is available, tap water is okay. Otherwise, we can use buffered solutions or any normal saline or RL or amphoteric solutions. In acute phase, the main objective of treatment are to decrease inflammation, avoid further epithelial and stromal breakdown, and foster reepithelialization. So this anti-inflammatory therapies should be given like topical steroids, which are critical in controlling acute inflammation and reducing the resulting inflammatory damage to the ocular surface after a chemical injury. It also for prevention of a stromal melt or thinning, it's a major concern in severe chemical injury. For that, we can use collagen inhibitors like tetracycline, ascorbic acid, cysteine, or protease inhibitors like aprotinin or citrate. Then we have to promote a reepithelialization. For that, we have to use frequent preservative-free lubricants, prophylactic antibiotic eye drops, avoid any toxic medications like gentamicin. Bandage contact lens can be applied. In acute settings, soft bandage contact lenses can be used. For that, amniotic membrane transplantation is a very good tool to promote reepithelialization. It acts as a permanent surgical graft to provide a basement membrane for epithelialization, and it acts as a biological bandage contact lens. In acute ocular burns, it provides pain relief and rapid reepithelialization. In moderate grade burn, AMG during the first 7 to 10 days following acute injury maximizes the beneficial effect. So here is a surgical video to apply the amniotic membrane. First we have to remove all the necrotic tissue from the ocular surface. Then we have to put amniotic membrane over the ocular surface, and we have to well spread over it. Then with the help of fibrin glue, we have to spread the amniotic membrane over the ocular surface, including the fornices and lid margins. So these are the outcomes after amniotic membrane graft in this case. Another tools for reepithelialization are using autologous serum and platelet-rich plasma. Tenonplasty is done in severe cases that cause loss of limbal vascularity and subsequent interior segment necrosis. It helps to re-establish the limbal blood supply and to promote ocular surface repair. It may be combined with amniotic membrane transplantation with or without laminar corneal patch grafting. It prevents anterior segment necrosis, scleral ischemia, melting and sterile ulceration. So here is a surgical video for that. So first we have to remove all the necrotic tissue from the ocular surface, and we have to reach up to the vascularized tenons. Then vascular tenon should be advanced and it should be fixed over the bare sclera. It may be combined with amniotic membrane transplantation also. So in chronic phase, the goal of surgical intervention is to restore normal ocular surface anatomy and visual function. The typical order for surgical intervention is correction of eyelid abnormalities, management of glaucoma, ocular surface reconstruction and keratoplasty. So eyelid and fornix abnormalities should be corrected before any limbal or corneal surgery is performed. In limbal stem cell deficiency, we can see corneal conjunctivalization, corneal neovascularization, persistent epithelial defect and ulceration. Corneal scarring, severe visual loss and chronic pain are the other features. So the management of limbal stem cell deficiency depends on the severity and laterality. Like in partial stage, we can do non-preserved lubricants, autologous serum eye drop and topical vitamin A plus steroid. In unilateral disease, we can use conjunctival limbal autograft, conjunctival limbal epithelial transplantation and slit technique. In total stem cell deficiency, or if there is bilateral disease, then we have to do living related conjunctival limbal autograft, keratolimbal autograft, yellow slit, yellow clot and comet. And in the end stage, keratoprosthesis can be done. So limbal stem cell transplantations are not recommended during active inflammation. It is delayed until ocular surface inflammation has subsided or is well controlled with medications. All eyelid abnormalities should be addressed before considering LSCT. This is the claw technique. Just in claw technique, we have to first remove the and the cornea. Then we have to procure conjunctival limbal autograft from the other side. And we have to fix over the area with the help of fluid. Another technique is slit, which is very good technique in chronic stage where we have lot of limbal stem cell deficiency, and we have to first remove all the pannus from all around the cornea. Then amniotic membrane is spread all over the ocular surface, and the limbal autograft taken from the other eye is spread over it and stuck over it in the small pieces, and then bandage contact lenses should be applied. So these are the other techniques. If all the surgical treatments are failed, then in the stage we have to do keratoprosthesis surgery, which is surgical placement of artificial cornea, and it is effective in managing repeated corneal graft failure. If in the stage disease, we can use Boston type 2 keratoprosthesis also. So to conclude, ocular chemical injuries are true ophthalmic emergencies. Early intervention in immediate phase is a must, and there is a correlation between time of irrigation and outcome. Management is based on this stage of presentation since injury. Eyelid and fornix abnormalities should be corrected before any limbal or corneal surgery. Thank you.
Thank you, Dr. Abhishek, for the elaborate presentation. As we are running set of time, I'd like the next speaker.
Okay, thank you.
Dr. Darsya, because the machine is not here.
The single pass four-throw technique has been popularized by Dr. Amar Agrawal, and that is very, very useful. Some of the indications are irregular people with floppy iris, to make the people small during the penetrating keratoplasty, floppy iris after removal of the legumoid and PK, traumatic mydriasis, coloboma of iris, and eccentric people affecting the vision. Generally done in pseudophakic eyes if it's not PK, and in phakic eye also you can do it. So I'm going to show you some snippets. So the main emphasis is given on the phakic eye. So for the tip, let the 10-0 or 9-0 thread needle pierce the iris and not the 26 gauge needle while coming from at the exit side. In modified SFT, 26 gauge needle can be avoided and cosmetically looks better because there is no hole in the iris. And you put the phakic eye in case of pupil reconstruction. So my this is self-explanatory. This PK with the SFT to avoid complications of floppy iris. These pupil is very nice central circular. SFT in lower segment only for the traumatic pupil repair, and the pupil plays its constricts and dilates also. PK with IOL and SFT. There might be some exudates in the pupil area, but it clears off later on. PK with IOL and SFT. Many times we require the pupilloplasty in cases of penetrating keratoplasty. There are exudates, but it clears off. In coloboma repair, we give 1 or 2 stitches. In pupil dilatation is not an issue, it dilates. Pupil movement is not an issue. Therapeutic graft with SFT before the surgery, after the surgery. Repair for the roughest pupil gap is good. It works as a PI. Tightening may not bring the two ends together, and then you can see some stitch in lower quadrant. In deficient iris tissue, it may be difficult, but this will do at least better than what it was. The remaining gap works as an inferior PI. And it helps preventing the IOL to come forward into the pupillary area and outside the pupil. Sometimes you have to do the SFT in the upper quadrant. Now the SFT in phakic eye. How do we do it? You insert the viscoelastic, remove all the posterior synechia and anterior synechia. Make the iris free from all the adhesions. Patient is phakic and he is young, he is 26 years age. You have to break the adhesions properly so that you can bring the two ends together. Then what I do is I inject the phakic IOL. Put it behind the iris. And then you start the SFT. The entry side. You have to see to it that the needle holder that you're having is good one, because it may slip away and the direction might change. Same thing is repeated on other side. because we have put the phakical, it is not touching the crystalline lens. The lens remains safe. And after taking these 2 bites, what we do is we remove the phakical, which is not difficult as you might think. And then you tie the knot. That's it. Thank you.
Thank you, Dr. Kashyap, doing such wonderful videos and the novel way of doing it. Any questions?
I will just to save the crystalline lens only.
Exactly.
Okay. Another other thing, which switcher you are using?
1009 Auro Lab. Yeah.
With the state video.
Instead you make it bend. You bend it. Where do you bend it? You measure the white to white measurement, take the white to white measurement and bend it there. Then you are very comfortable. And you must have a very good needle holder forceps. Needle holder.
In one case I have seen that you have tied the iris in between and there are 2 pupils. So there is any problem with diplopia after that?
No, there's no diplopia. Listen, you know, sometimes the iris tissue is so deficient that you cannot make the iris, the people look very small. But then at least something is better than nothing. And then while doing this, you make it sure that, you know, there is no crowding in the anterior chamber angle. It's not crowded, so it helps you out.
Thank you, Dr. Kashyap.
Thank you.
We'll move on to the next speaker. Dr. Dilip Yadav is there. I think Dr. Basian is also not there. Close the session. Thank you. Thanks all 3 of us. No one is there.